Good afternoon, and welcome to this month's Employee Benefits Compliance webinar, our first one of the new year. I am Jenny Bedeau with Assurex Global, and thank you for joining me here today. Today, the experts from Benefit Comply will be reviewing 2025 federal reporting requirements. And as we are getting started and as folks are still joining, we would like to kick off by asking our audience a couple of polling questions. And you should see those up on your screen now. You can see we're asking you two questions about your annual enrollment. First, we're asking about any opportunities to improve your annual enrollment process. And make sure to scroll down where we have a second question around which core employee benefit other than medical did you promote the most during your recent annual enrollment? And as you are submitting those responses, I'll cover a few other items. First, I'd like to extend a special thank you to your local insurance benefits advisors and consultants who are partners of Assurex Global for making today's webinar possible. And we do welcome your questions today. If you have questions at any time during the presentation, please submit them using the Q&A function at the bottom of your screen. And our sessions are recorded, and a link to the recording, as well as a copy of the presentation slides, will be available early next week from the benefits advisor who invited you here today. And I will also drop a link to the presentation slides in our chat section here in just a couple of moments. And I see responses are still coming in on those polls, so I'll leave them up here for just another few seconds or so. And I will share, we actually asked the first question, the annual enrollment opportunities. We've asked that now the past couple of years, and we are curious to see if responses have changed noticeably from when we've asked this in the past. So just to share a little bit, last year and the year before, increased education of the benefits program was the top choice. And last year we saw change how we communicate the benefits program as the second choice. And a quick glance tells me we're looking pretty consistent from last year. So I will share these results out with you here so you can get a feel for how your peers responded to both of these questions. Okay, and it looks like spending accounts were the benefit other than medical, which I assume most of you probably put the most focus on. So spending accounts were the employee benefit that you highlighted the most. So we always appreciate your responses. Please be sure to stick around for my closing comments where I will have an additional poll question for you. But for now, let's get into today's presentation. Joining us from Benefit Comply, we have Regan Devon, Principal, and Delaney George, Consultant. So Regan, I will turn it over to you.
Thanks, Jenny, and thanks everyone for joining us today. We've got kind of a full packed agenda for you. You can see, not going to go through the list here. Instead, what I'd like to take you through, we're going to talk about and focus on different reporting requirements to federal agencies. So this is not about notices and communications to employees. That's not the focus. This is really kind of all the different reporting requirements that group health plans primarily, sometimes ERISA plans, are subject to throughout the year, and kind of take you through that calendar. In doing that and touching on so many different topics, we've got them all here. We're not going to be able to do a deep dive on any one of these. We'll kind of just give an overview of these different requirements and try and help you understand what they are and whether they apply to you, whether you may have a role to play in ultimately making sure that this reporting gets done. And then from there, it would be appropriate for you to reach out to your broker, that partner that invited you here today, to get some more detail if that's needed, and potentially even get some help finding solutions to help you with some of those things if needed. So to kind of take you through the agenda, we thought a timeline might be helpful just to kick things off. I want to note that this timeline is specifically tied to a calendar year plan. A lot of these dates are fixed, and we'll make sure and confirm that as we're kind of going through, but specifically creditable coverage reporting for prescription drugs, as well as Form 5500 filings, are tied to your plan year. So if you have other than a calendar year plan, the dates for those two things would differ. The rest of these things would be the same. So today we'll touch on cost of coverage reporting for Form W-2s, because that has to be included on the W-2s that have to be ready to go by January 31st, just around the corner. Then for a calendar year plan, creditable coverage status reporting to CMS is supposed to happen 60 days following the beginning of the plan year. So for a calendar year plan, that would be March 1st. Then Form 1095s need to be distributed to employees by March 3rd. I know I said the focus was kind of on reporting, but just because that's so closely related to the reporting that has to be submitted to the IRS by the end of March, we're talking about both of those pieces together. Then the prescription drug reporting that was added a few years back has to be reported every year by June 1st. The PCORI fees, if you have a self-funded medical plan or HRA, you have to report and pay PCORI fees every year. The deadline for that is July 31st. And then if you've got a calendar year plan, Form 5500s for the previous plan year would be due by July 31st as well. And then the final one on our timeline is gag clause attestations. That's again kind of a newer one that was just added over the last couple of years. That has to be done at least once a year by December 31st would be kind of the deadline for that. And then the final thing that we're going to touch on today, it's not on the timeline because there isn't any specific requirement to submit it to a government agency or to do so within a particular time frame. But the mental health parity rules, the written comparative analysis component of that is something that is, a lot of employers are kind of hearing about. We got final rules further clarifying what's required around that. It's something that you need to have a written kind of analysis done and available upon request. And so we're going to touch on that briefly before we wrap up today as well. But with that, I'm going to turn it over to Delaney to kick off on the first topic and give you a little bit more detail.
Thanks, Reagan. Okay, we're starting off slowly here with the cost of coverage reporting on Form W-2s. That is required for any employers who filed 250 or more Form W-2s in the previous year. Originally, when this cost of coverage reporting came out, it applied for all employers, but the IRS did issue, it was meant to be transitional relief back in 2012, that only employers filing 250 or more W-2s would be required to do this reporting, but that hasn't changed. That has stood. And so only those folks will need to do that, will need to be required to do that. The number itself that gets reported is only used for informational purposes. So it won't have any effect on the employees or the employer's taxes. Frankly, we don't really know what the IRS does do with that information, but we do know that it is not to dole out penalties or fees or anything like that. It's just information gathering. And then the number that they want in this reporting is meant to be representative of the cost of the entire plan, meaning that it would include both employer and employee contributions so that they can see what the total cost of that plan is. It would refer to the cost of just group health plans, but not HRAs or accepted benefits. So limited scope dental or vision plans would not be included. HSAs would also not be included. Additionally, things like wellness discounts or smoking surcharges, those things would not have any effect on the number that gets reported here, because while they do shift a portion of the cost between employee and employer, the total cost of coverage, which is being reported here, would not be affected by those things. That reporting is just done on the Form W-2 in box 12, where various employee benefit items get reported. The total cost of coverage reporting would use the code DD. You may also recognize the box 12 for HSA contributions that get reported using a different code, code W. And that's really it for this cost of coverage reporting. That will just be done with that Form W-2. There's no separate form, luckily. And that really sums up this reporting requirement. So we'll kick it up a notch with creditable coverage status reporting. This was a pretty hot topic in the last year or so because of changes being made to Medicare Part D coverage. And that lends itself to this because the Medicare Part D coverage is part of what defines whether a plan is considered creditable. A group health plan prescription drug coverage will be considered creditable if it provides value that's at least equal to, if not greater than, the actuarial value of the prescription drug coverage provided under Medicare Part D. So as Medicare Part D coverage was improving, actually, that effectively raises the bar for what it takes for a plan to be considered creditable. Whether a prescription drug plan will be creditable, hopefully that's determined by your carrier, or your TPA may be able to assist you with that determination. Otherwise, the employer, the plan sponsor, will need to make that determination of creditability. They can do that using a simplified method that CMS provided for making this determination. Or otherwise, the only other option really is to use an actuarial determination to see whether your prescription drug plan meets the Medicare Part D value. Now we want to look at why creditable coverage, creditable status matters. And let me first say that it does not matter for the purpose of any kind of penalty for employers. Employers are not required to provide creditable coverage. More so, it matters for the employees to be aware of that creditable status for when they need to decide between Part D or their employer prescription drug coverage. Because once an individual becomes eligible for Medicare Part D, they can delay enrollment without incurring any kind of penalty, but only if they have creditable prescription drug coverage. So if you're eligible for Part D, if you go without creditable prescription drug coverage for 63 days or more, then whenever you do eventually enroll in Part D, there will be late enrollment penalties incurred. And the way that Medicare late enrollment penalties are applied, they're applied in the form of a higher monthly premium generally. So that can be significant to incur those kind of penalties. So for those folks, it's just important for them to be informed of, whether their prescription drug coverage provided by their employer is creditable or not, just so they know what they're really, signing up for in their decision of whether to enroll in Medicare. Importantly, individuals will be eligible for Part D only if they're enrolled in Part A or Part B. And individuals who are just eligible for Medicare generally, but not yet enrolled in Part A or Part B will not be eligible for Part D yet. So that they won't start incurring those, they won't potentially start incurring those late enrollment penalties, even if they don't have creditable prescription drug coverage. To this point too, when a plan changes creditable coverage status, more specifically when a plan loses creditable coverage is when this would be relevant. A special enrollment will be triggered for those folks who are Medicare Part D eligible, so that when they lose that creditable coverage, they'll be able to hop on Part D right away versus waiting for an open enrollment period, so that they can, again, avoid incurring those late enrollment penalties. To that end of, informing employees of that creditable coverage status, you may be familiar with the creditable coverage notice that does need to be distributed to eligible individuals on your plan, or eligible individuals for your plan. The notice needs to be distributed upon an individual's initial eligibility for the prescription drug plan on an annual basis. And then again, whenever there's a change in the plan's creditable status. You'll often hear the date October 15th when referring to this creditable coverage notice. The requirement is that this notice needs to be distributed, quote unquote, prior to October 15th. And the way that CMS defines prior to is anytime in the previous 12 months. So as long as, you know, an employer is meeting these 3 bullet points of distributing the notice, at least as long as it's annually, they'll be meeting that, you know, October 15th requirement. There are also model notices available on the CMS website for both plans who are creditable and those that are not creditable to be distributed for this purpose. And then we have the creditable coverage reporting, you know, what was on the timeline at the beginning of the presentation. This is one of those reporting requirements that does change with or depends on when your plan year is, because the report is due to CMS within 60 days of the start of each plan year. So again, like the timeline, you know, for a calendar year plan, that'll mean March 1st is the deadline for reporting your creditable coverage status to CMS. That report would also need to be made within 30 days of any change in creditable status, if it does change mid-plan year, and within 30 days of a plan's termination, if it terminates mid-plan year. The disclosure is done exclusively online. There's no mail-in form or written reporting done. It's just an online form. It's pretty simple. Even, you know, if you make a mistake in your disclosure, the amendment process is simply to make another disclosure. Just resubmit and it'll overwrite whatever you previously submitted. There is actually no specific penalty related to failing to make this creditable coverage reporting. That said, it is still required. So for full compliance, you do still want to make that creditable coverage report. And it helps CMS to identify where, you know, Medicare eligible individuals may have other creditable coverage available to them. And so it's still important to get done. All right. Now I think Reagan's gonna kick it up a few notches with
Yeah, I will.
ACA.
Before we jump into
Mhm.
that, I was gonna just comment on a couple of the questions that came in. If we go back to where you started, Delaney, with the Form W-2 cost of coverage reporting, there were some that commented that there are some extensions available in certain parts of the country due to some of the natural disasters and things happening. That is absolutely true. We were giving a very generalized, you know, most employers are subject to that January 31st deadline, but please follow wherever, if you're in a certain part of the country and you've got an automatic extension, that would apply obviously to the cost of coverage reporting as well, that would just have to be reported whenever your W-2s are due. And then just a quick clarification on the actual cost of coverage reporting. Somebody asked about what if it's a different tier of coverage? Are we just doing the employee only coverage, or is it, you know, what if they enroll in family? It would be whatever they actually enrolled in. So if the employee chose to cover their entire family, that is the cost of coverage that should be reported. Just keep in mind here, you know, Delaney said it, but it's for employers that filed 250 or more W-2s in the previous calendar year. If you filed something less, you don't actually have to do that part of the W-2 at all.
Mhm.
And then similarly, just kind of a size question again for creditable coverage reporting, that is not tied to size. If you offer prescription drug coverage at all, you are responsible for determining whether that's creditable or not. Not required to offer creditable coverage, but you have to to make that determination of whether it is or not, and then communicating that to eligible employees. Technically, you only have to communicate that to Medicare eligible employees, but because you're not already always going to know that, especially for spouses and dependents, the recommendation is that you just go ahead and communicate, send that creditable coverage or non-creditable coverage notice to all eligible individuals. And then regardless, you have to send the reporting. If you offer prescription drug coverage, you have to do this reporting that Delaney explained. That's kind of the focus today. There isn't a size kind of exemption for that, or it doesn't matter, that you do have Medicare eligible employees or you don't. If you offer this prescription drug coverage, you're supposed to determine that creditable status and report it to CMS every year. All right. Jumping into ACA employer reporting, which we are in the thick of right now. So first of all, focusing in on who has to do this reporting. Hopefully, if you are in one of these buckets, you are well aware and in the midst of preparing these for 2024. But the two buckets of employers that are subject to the employer reporting, first of all, are applicable large employers, those that averaged 50 or more full-time equivalents, either on their own, or if you have a bunch of different entities that are part of a larger controlled group due to common ownership, or part of a larger affiliated service group because there's shared management and services, even if they have different EINs, they would then be aggregated to determine whether they hit this 50 or more full-time equivalents. We always look back to the previous calendar year to determine status. So for right now, to decide who has to do the reporting, we're looking all the way back to 2023. If the employer averaged 50 or more full-time equivalents in 2023, then the employer was an applicable large employer for 2024 and required to offer minimum value affordable coverage to full-time employees throughout 2024. And then now that's what's being reported in 2025 is who was full-time, did they get an offer of coverage, did it provide minimum value, was it affordable? We're basically self-reporting on whether we complied or not during the 2024 calendar year. And employers do that, applicable large employers do that using the 1094C and the 1095Cs. The other bucket of employers that have to do the reporting, or maybe do some additional reporting if they're in both buckets, are any size employers. There's no small employer exemption. If you offered a level funded or self-funded group medical plan or HRA during 2024, maybe a retiree HRA, I should say, if it's bundled with your other coverage, you can ignore it. But self-funded, level funded plans, you're required to just report coverage information, who actually enrolled in your plan during 2024. Not only employees, but their spouses and dependents as well, COBRA participants, retirees, anybody that shows up as enrolled in your plan during 2024, you should see them on the reporting with their name, social security number, and months of coverage. If you're a small employer that doesn't have to do the C forms, then you just report that coverage information on the B forms, 1094B and 1095Bs. If you're an applicable large employer already completing the C forms for what we first talked about, then you would go on and complete Part 3 for any individuals who enrolled in your self-funded plan during the year to show their months of coverage. As far as the deadlines for this, if you're mailing the submissions into the IRS, it's February 28th. To provide copies to individuals, it's March 3rd. And then we have to submit things if we're doing it electronically to the IRS by the end of March. And I'm going to very quickly pull that first deadline off. It's not really relevant anymore, even though it's still in the instructions and things, because last year and then now indefinitely going forward, any employers filing 10 or more tax forms, including 1095s, W-2s, 1099s, are required to now file electronically with the IRS. There isn't an option to do it by mail anymore. So that February 28th deadline really went away. And what we need to focus on for 2025 is making sure that copies go to individuals by March 3rd and that we submit everything electronically to the IRS by March 31st. Now we're going to talk about what many of you have been asking. I know a bunch of you are saying, hey, I thought there were some changes here around distributing the 1095s. So we're talking about that now. There was legislation just signed into law at the end of last year, actually December 23rd, President Biden signed the legislation, giving us several different kind of small employer reporting changes. It certainly didn't make this go away, but hopefully simplifies things slightly in some places for you as you're doing the reporting. Perhaps the most importantly is the first one on the list here, that there's an alternative method for distributing the 1095s, that instead of having to either hand deliver, mail, or provide these electronically, that employers could post a notice of availability instead, and then just only give them out if they're actually requested. We're going to talk a little bit more about that one in just a moment, but I want to also go through the other changes. They gave a little bit more flexibility around obtaining electronic consent. So for those of you who plan to still distribute them rather than just posting notice of their availability, prior to this legislation, you would have to get consent specific to the 1095, and you would have to get that consent annually to provide it electronically to individuals. Now, if you get consent to deliver it electronically, you can rely on that consent indefinitely. You wouldn't have to get it every year until it's revoked. So just making it a little bit easier to collect that consent if that's the path you go. For those of you who have to report coverage under a self-funded plan, a little bit more flexibility to use the date of birth versus social security number, primarily for spouses and dependents. You're still going to need accurate name and social security number for your employees, not only for this, but for broader purposes. But specifically for covered spouses and dependents, it can be difficult to get that social security number or tax identification information. So certainly you should still ask for that, but then ultimately, if that's not available, easier to then jump and use the date of birth instead when that's appropriate. Then finally, we do, like I said, for applicable large employers, this is basically self-reporting, telling the IRS whether you complied with the 4980H offer of coverage requirements or not. And based on that reporting, if it looks like there's some penalties owed, the IRS sends out what's called a letter 226J. And hopefully many of you have not seen those. But to the extent that you have, there is an option to appeal those and basically respond saying, no, we offered what we were supposed to do. We made some mistakes in the reporting or whatever it may be. Historically, they put a 30-day response time on those. They were often flexible with that, but in this legislation is going to require them to give at least 90 days. So just a little bit more flexibility for the employers to be able to respond to those letters if they get them. And then also they are currently enforcing for 2022, and we think, in the next 6 months or so, they'll be moving on to 2023. They're slowly kind of getting caught up with where we are at for the reporting. But as far as, lots of employers saying, well, how far can they reach back and look at what we've done and whether we got it right or not, or impose penalties? And they did put a formal 6-year statute of limitations in place. Prior to this, there wasn't one. All right, and as I promised, I know this is where some of the questions were, especially for employers who are looking to potentially take advantage of this change already this year for the 2024 reporting, which the legislation says you can. We don't have formal IRS guidance yet, letting us know exactly how to satisfy this kind of notice requirement. But if we look, they previously gave us guidance specific to the B form. So this is not a brand new concept. For small employers and then for carriers that were preparing the B forms in prior years, they had this alternative kind of option to post notice of availability rather than mailing out copies of all the 1095s. So if we look to that and follow that until we hear from the IRS that it's the same, or if it's something different, we'll have to make changes. Basically, what they required is a clear and conspicuous notice on the employer's website, or potentially intranet or benefits portal, but you have to be careful there. Make sure that's going to be available to terminated employees who may need these forms as well. Just with information about where to ask for these forms and get a copy if it's something that they want. And so we created an example here. I just want to be very clear that this is not something that we got from the IRS or a model template of any sorts, but just something that we threw together that may meet this requirement until we hear more from the IRS. But something like this then should be posted on the employer's website, and you're really supposed to keep that up until October so that if individuals are looking for the 1095, they would find this and know where they could request a copy. The next one we wanted to touch on was that prescription drug reporting, or they've labeled it the RxDC reporting. That's what CMS, their website and instructions, that's what they call it. This is really part of the broader transparency legislation. It was just one of the many ways that they are trying to get more information out and publicly available that we can digest and analyze and look at and hopefully get a better grip on kind of healthcare spending and costs, make it more affordable and more available to the general US population. So they have these plan files, 8 separate data files and narratives that are required to submit all kinds of information about the group health plan spending. A big portion of that really focused on prescription drug spending. This can be reported by the employer. It can be reported by the carrier, by the TPA, by the PBM. It can be reported by multiple parties. So all of these different files, maybe the TPA is submitting part of what's needed, the PBM is submitting the rest. Maybe the employer has to submit a portion. Ultimately, it's the employer's job to kind of play quarterback and make sure that everything gets into CMS. Over the past couple of years, we've really seen that the bulk of this responsibility is being handled by your service providers, that they're sending this in on behalf of your plan. But you do want to make sure that you are asking questions and making sure that this is happening on behalf of your plan. It is really primarily focused on major medical prescription drug, if it's part of that or as a carve out. It is not for account-based plans, so we don't have to worry about HRAs. We also don't have to worry about accepted benefits like limited scope dental or vision or a health FSA. I'm not going to go through all of the different files, but I've just got them here more so to illustrate the type of information that's being collected in the different files. Because so much of this is being handled by the carriers, PBMs, and TPAs on behalf of group health plans, CMS has actually asked that the information be submitted on an aggregate basis. And I want to mention that because if they're reporting kind of on their book of business, or at least within a market segment, they're not reporting on a plan-specific basis. If that's what they're doing, I know some employers thought at first they'd be able to get all of this additional information about their plan and the spending, and that's not necessarily the case. If you reach out and try and access these files when they're being done on the aggregate basis across the service provider's book of business, it's not going to give you plan-specific details. As far as responsibility for this particular reporting for a fully insured group health plan, the carrier is going to take care of most of this. So unless you have some carve-out arrangements elsewhere or other add-ons that are subject to this reporting, you probably don't have to do anything as part of this process other than, and I've got it here as the second bullet point, the one of the pieces of reporting that's needed is for the average monthly premiums, they ask for the employer and the employee split. They want to know how much the employer is covering and how much the employee is covering. And carriers aren't necessarily going to know that because the employers are setting those. Some carriers are just going to assume, we require 50% to be covered by the employer, so we'll just use that and we'll just, kind of generalize the data. Others are going to ask for that information from you. So just kind of understanding why they're reaching out and being timely in your response so that can get appropriately included in the reporting. If you don't do that, some of the carriers take the approach that then, okay, employer, if we didn't get a response, now you have to do a portion of the reporting, specifically the P2 and the D1 forms on your own. For the self-funded group health plans, it's a little bit more of a mixed bag. Perhaps more likely that the employer might have to do a portion of it, but primarily it's going to be the TPAs and the PBMs that have the data, and much easier for them to report, especially on an aggregate basis versus trying to get you all the plan-specific level data. The employer may still have to provide that employer-employee kind of contribution information and some more plan-specific information. So again, possible the employer would have to complete the P2 and the D1 files. Very likely in most cases that the TPA and PBM are taking care of the rest.
Reagan, I just wanted to address one question. We get more questions on that new 1095 notice of availability. So I just wanted to clarify this new alternative method of distribution does not require the employee's consent. We're just, as Reagan said, we don't have the IRS guidance specific on how exactly to execute this new alternative method to distribute electronically without consent. But another way to distribute electronically compliantly would be to get employees' consent too. Just wanted to make that
Yeah, so
clear.
this is really, it's not even delivery, right? It's just posting notice that it's available. If you look at the instructions for the B forms, there's quite a bit there. And
Mhm.
what they say is that if an employee actually requests a Form 1095, then we're back to kind of the same rules. You either have to hand deliver or mail it, or if at that point you want to provide it electronically, the instructions say then you would have to get consent to do so. So that's kind of like a separate process. And really it's just, I think it's recognizing that most employees don't actually need these 1095s. And so instead of having them, send these out in mass, let's just post them, make sure not even post them, just post a notice saying these are ready and available. If you'd like one, let us know. We're happy to send it your way.
Okay, something a little bit more familiar perhaps
Yeah.
is Form 5500 reporting. This is an ERISA filing requirement, so it's going to apply to ERISA plans, and it'll apply to large plans and funded plans. For this purpose, large plans are defined as plans that cover 100 or more participants as of the beginning of the plan year. So that's just the first day of the plan year, how many participants are covered. And for this purpose, the definition of participants only includes current and former employees. You would not count any enrolled spouses or dependents for this purpose. And they're looking at obviously the current employees who are enrolled, and then former employees who are enrolled. Those may be retirees or COBRA participants. You also included in this count would be anybody who is within their COBRA election period as of the beginning of the plan year. That first day of the plan year would also be counted for this purpose. And just to emphasize, if you have 50, if you have 99 enrolled participants as of the first day of the plan year, then regardless of whether you get more enrollees throughout the year, this Form 5500 filing requirement would not apply to you as a large plan. It may apply if your plan is funded. All funded plans, regardless of size, will need to comply with the Form 5500 filing. A funded plan refers to one that a plan that has their funding held in a separate account or a trust versus a plan that is funded by an employer's general assets. And I want to clarify that whether a plan is funded or unfunded is a separate question, separate categorization than whether a plan is fully insured or self-funded or level funded. These are two different labels for plans, where an funded plan has its own bank account. An unfunded plan just has its plan costs paid from an employer's general assets. The Form 5500 filing is required for all ERISA plans. We have some of the more common ERISA plans listed out, like your major medical, dental, vision. Some that would be not ERISA plans, so would not require a 5500 filing, are your cafeteria plan, DCAPs, and HSAs all would not have their own 5500 filing. The 5500 requirement is an ERISA requirement. So some employers or plans are just wholesale exempt from ERISA completely. So government employers and church plans, as they are exempt from ERISA completely would also be exempt from the Form 5500 filing. The details, this is one of the reporting requirements that, again, the due date is based on when your plan year is. The Form 5500 will be due on the last day of the 7th month following the end of your plan year. For calendar year plans, that's July 31st. For other plans, that, yeah, you'll have to do the math. There's also a 2.5-month deadline extension available via a Form 5558. And as long as that Form 5558 gets submitted before the original deadline, so July 31st for calendar year plans, so long as that form is submitted before that original deadline, that 2.5-month extension is automatic. There's no approval process or anything like that. It's just, you get it submitted and it's granted. How many Form 5500s each employer would have to submit depends on how many ERISA plans they have. If you don't have a wrap plan, then each of the plans that were listed in the previous slide would require its own 5500 filing. So your dental plan, your vision plan, your medical plan would all have their own 5500. However, one of the major pros of having a wrap document, and why we always recommend it, is because what a wrap document does is bundle all of those plans together to create a single ERISA plan. And therefore, you only need a single Form 5500 filing. There are also situations where multiple employers share a single ERISA plan. You have multiple EINs or tax IDs, but this filing requirement is on a per ERISA plan basis, not a per employer basis. So even in those cases with multiple employers, only one filing will still be required. The Form 5500 is filed electronically exclusively. Again, there's no mail-in option. Just has to be electronically via the eFast2 system under the DOL. What the Form 5500 submission will look like, they'll all have the main body of the form included. Fully insured plans would also include a Schedule A. Self-funded plans, though, won't include a Schedule A. So we'll get that question sometimes from folks who switch from a fully insured plan to a self-funded or a level funded plan. And they're, hey, where's my Schedule A? I need it for my Form 5500 submission. No, you don't. The self-funded plans won't have that Schedule A attached. Right. Now we have PCORI fees, another annual reporting requirement. This comes from the Affordable Care Act, which when it was passed, it created a nonprofit corporation, the Patient-Centered Outcomes Research Institute, where we get PCORI. This institute supports clinical research that benefits the healthcare industry as a whole. The ACA also dictated that this institute would be at least partially funded by fees paid by insurers and sponsors of self-funded plans. So those group health plans, whether it's the carrier or the plan sponsor of a self-funded plan, then must pay a certain fee, approximately $3 per covered life in the plan. Originally, when the ACA was passed, this PCORI fee would only apply to plan years ending approximately between 2012 and 2019, but then it was extended for another 10 years. So PCORI fees will be around for at least until 2029. It may be extended again, but it'll still be on your to-do list for now. If you have any more questions about what the Institute does, what these fees are paying for or help paying for, there is a web page that you can go to check that out too. So as I mentioned, this PCORI fee is per group health plan. So that would not include accepted benefits, again, like the limited scope dental or vision plans. Health FSAs would not be included. So you're primarily looking at your major medical plans and HRAs, which are, in their most basic definition of a self-funded health plan. So who has to do the reporting, as I mentioned, will depend on how a plan is funded. And by that, I mean whether they're fully insured or self-funded. Again, a different question from funded versus unfunded for Form 5500 purposes. But for fully insured plans, your carrier is taking care of this. You don't need to worry about it. Unless you do have an HRA, then you may need to look into that. For self-funded plans, then the plan sponsor, you as the employer, will be responsible for making the submission, which again, you'll have an annual fee that gets adjusted every year for plan years ending in 2024. The fee is either $3.22 or $3.47, depending on which month your plan year ended. And then you multiply that fee by how many covered lives your plan had. Covered lives, for this purpose, you count not just the employee as the primary subscriber, but you do also count spouses and dependents generally. There are some special counting rules for certain situations when you may have an integrated HRA that you may be able to ignore spouses and dependents in certain situations. But for the most part, they should be counted. And there are 3 definitive counting methods for this, for counting covered lives. I won't go into the details of these 3, the actual count method, snapshot, and Form 5500 method. More so just pointing out that there is a right way and a wrong way. Well, there's 3 right ways, and then there's everything else on how to count your covered lives for this purpose. PCORI fees, the due date will always be July 31st. Which July 31st will depend on when your plan year ended. It will always be due the July 31st of the year following the end of the plan year. So for any plan years that ended in 2024, whether that was December 2024 or January 2024, their due date for their PCORI fees will be July 31st, 2025. Importantly, this PCORI fees apply on a per plan year basis. So when you have a short plan year, you may end up paying 2 PCORI fees on one July 31st because you had 2 plan years end in a single calendar year. Therefore, they both have the same deadline of that July 31st for their PCORI fee submission. The PCORI fee is paid for via the Form 720. This is a quarterly tax form. It has, besides the PCORI fee, there's all sorts of things that get reported on this Form 720. So you may be already submitting this Form 720 on a quarterly basis for any number of reasons, or you may not need to submit the Form 720 for any reason except the PCORI fee, in which case you'll only file it for the second quarter. It's important that the PCORI fee is part of your second quarter filing of the Form 720. That's a frequent question that we get. My plan year just ended in October. Can I just submit that PCORI fee and, get it off my desk in my next Form 720? And the answer is no. You really want to wait for that second quarter filing using lines 133C and D for self-funded group health plans.
Home stretch, last two things on the list. Gag clause attestations, maybe you're groaning because you just finished this and then we're already talking about this again for 2025. We did just actually get some FAQs around this week. So they are thinking about this and caring about, really their primary concern is, again, this is part of the broader transparency legislation that was passed a few years back, is that they don't want contracts to have gag clauses in them that limit the information that's being shared. And historically, they have been in most contracts. I think, unfortunately, what they're finding is that there are still a lot of gag clauses in the contracts, specifically contracts between the group health plan and its service providers. So we got this prohibition that said, you can't have these gag clauses in your contracts. The FAQs say it's not enough just to remove the gag clauses from the contracts with the insurance carriers, TPAs, PBMs, but also the downstream contracts. If those parties are then turning around and contracting further to ultimately kind of build out the network and service the plan, those contracts are subject to this as well. And so what they've said is, employers, you need to ask your TPAs, carriers, PBMs, other service providers, not only whether the contracts with them are okay, but also make sure going forward that you have them have something in those contracts that said they'll monitor and make sure that the downstream contracts don't have these prohibited gag clauses either. And then to further enforce this, to build awareness, to let people know, if you're being told you can't have this information, for example, because of a certain contract provision, that those are no longer allowed, then they ask employers as plan sponsors to also attest annually that they've looked at contracts, they've made sure, or else worked with their vendors, asked them to make sure that the contracts don't have these gag clauses in them, and that they have to go online and annually submit this attestation to CMS. There's a portal to do that every year. You have to do it at least once per year. When you do that is really up to you. So for example, maybe it makes sense for you to do it every year as you're going through renewal, because that's the time when you're changing contracts, when you may be working with different service providers. And then you can always just look back over the last year and say, for those providers that we had in place and those particular contracts, we think we're in good shape, and then go ahead and attest accordingly. This is the page, just kind of a picture of the portal that you go to. You basically submit an email address, get a code, and then use the combo of those two to get access to the form that needs to be filled out. For fully insured plans, and this is kind of a recurring theme today, carriers are likely to handle this on behalf of the fully insured plans. They will go on and do the attestation. Certainly appropriate to reach out and confirm that they're doing that on behalf of the plan, but that will almost be the case that they're doing that. For a self-funded plan, the TPAs, PBMs, other service providers, for telehealth, direct primary care, that are all subject to these requirements, they could go on and attest on behalf of the plan, but perhaps less likely that they're doing so. What we're finding more often is that they're just providing a letter, either proactively, or if you ask, they'll provide you something that says, we've reviewed our contracts, they're in good shape, we don't have any prohibited gag clauses. You as the employer then just kind of put those in your file, and then you can go on and attest and say, yes, we've checked into this and we feel good about saying that we're in good shape. And the final thing we wanted to touch on today, again, this doesn't have any particular deadline, but just something that you're required to do on behalf of your plan. Make sure it's been done, that it's kept current, and it's available upon request, is the Mental Health Parity and Addiction Equity Act comparative analysis. So MPIA, it does apply broadly to most group health plans. Any group health plan providing mental health or substance use disorder benefits. There is a small employer exception for private employers. It's less than 50 employees. For non-federal group health plans like your state, local, county government entities, the threshold is 100. However, the reality is that fully insured carriers are required to comply in the way that they design and administer their plans. So even if you're a small employer, if you're offering a fully insured plan, it's going to be set up to comply with these rules. So the only real exception is if you are a very small employer and you offer a self-funded plan, then you're going to be off the hook. The rest of major medical plans that offer mental health or substance use disorder benefits, which is most, are subject to these rules. And the general requirement is that the coverage for those benefits needs to be at least equal to or better than the coverage that's made available for medical surgical benefits. And to kind of assess this, to decide whether the coverage is in parity or not, they look at financial requirements and quantitative treatment limitations. So you think of things like co-pays, co-insurance, deductibles, as far as financial requirements. For quantitative treatment limitations, think of things like days or visit limitations. And there's kind of a mathematical test they do to look at whether those are in parity with the same things that are being provided to medical surgical benefits. The other thing that we have to look at are any non-quantitative treatment limitations, and they're a little trickier. Here, what we're thinking about are kind of medical management things. Is it medically necessary? Do we require that they get prior authorization before getting coverage? Do we require that they try something else first before they get coverage for a particular benefit or service? Those types of things, it's harder to provide a mathematical test to determine whether they're being applied in parity or not. And so one of the tools that they've put in place to try and better enforce this is the comparative analysis, requiring plans to go through, look at each NQTL, do an analysis and document that process to ultimately assess whether those are being applied appropriately or not. As far as responsibility for this, once again, if you are a fully insured plan, the carrier is going to handle pretty much all of this for you. They're going to make sure that the design is okay. They're going to make sure that the claims are being processed accordingly. They are going to be required to prepare a written comparative analysis. Now, that doesn't mean they're all perfect, but they are directly responsible for that compliance and will handle this on behalf of a fully insured group health plan. For a self-funded plan, that's not the case. The employer really plays a big role in making sure that everything is set up okay. And the TPA, PBM, and other service providers obviously play a large role in helping the employer be in compliance. But the employer needs to be kind of poking into and asking questions about whether the service providers that they're working with are capable and are carrying out what's required to make sure that the plan is in compliance in kind of design and how claims are being processed. And what we're seeing so far is not many of the TPAs are providing full written comparative analyses. So if they are, that's great. If they're not, at least making sure that they're going to help, that they're going to provide the data that's needed to really do the analysis and document it, likely sharing that with a third party and the employer getting some help doing that. That written comparative analysis itself, the final rules gave us further clarification on what the agencies expect to see, and that's what's here. For each NQTL, you would have to go through and kind of address these 6 different things, and that would make up this written comparative analysis. And then a new thing in 2025 is that this has to be certified by an ERISA plan fiduciary. They don't have to say, well, yes, we're exactly in compliance with all MAPIA requirements. Instead, they have to say, we vetted different vendors. We picked one that is able and competent to do this written comparative analysis on our behalf. We've seen the report, reviewed it with them. We understand kind of where we're in parity and where there might be some gaps and what actions we need to take. They're certifying that they went through that process. So that's what would make up this written comparative analysis. And then I just want to one more time make the point. This isn't sent in proactively anywhere, but the federal agencies or state agencies can request to audit it at any time. And ERISA plan participants can also ask for a copy of this, especially if they're going through and claims are denied or limited. They could ask for the relevant portion of this analysis, just showing why that was properly denied or not. With that, I know we are right almost up to the end of the hour. I want to make sure and leave a little bit of time. Jenny, I know you had a few more questions for the audience, but thank you so much. And just want to remind you, we went through so much today to reach out to your broker partner if you have specific questions about any one of these particular requirements.
Great. Thank you, Reagan. Thank you, Delaney. Thank you for getting us ready for 2025. As Reagan mentioned for our audience, I do have another quick set of polling questions for you and a couple of closing comments. So you'll see the polling question launch now. We've got a couple of questions for you now around your dental plans. If you made any changes to your dental plan in the last year regarding the design or the contribution structure, as well as if you contribute to the dental plan premium. So if you would kindly take a moment and submit your responses. I will also remind you that we did record today's session. And so if you would like a link to the recording, please reach out to that benefits advisor who invited you here today. They will be able to provide that to you. And if you have any more questions about today's content, as Reagan said, please also reach out to that benefits advisor. They would be happy to dig into any of this, or certainly if you have questions around the polling topics as well, please do reach out to that benefits advisor for assistance. And we do publish the results of these polls in various formats, including our monthly market check surveys, as well as quarterly infographics. So if you're curious to kind of learn more about how your peers are responding to these questions and kind of just hear some insights on them, please keep an eye out for those and reach out to your benefits advisor for those pieces as well. I'll give the poll just another second and I will share those results out with you. The quick sneak peek is most of you did not make any notable changes to your plan design or contribution. And most of you are paying a portion of the dental premium. But again, I'll give it just a second here as we have a few more responses coming in. Okay, so here's a visual of what those responses look like. Again, 79% of you didn't make any changes to the plan design or contribution, and about 57% of you are paying a portion of the premium. So as always, we appreciate you joining us. Thank you for sharing your perspectives on our polling questions, and that does conclude our time together. So thank you again and have a wonderful afternoon.